Hi, I'm Pastor David Lau from Emmanuel EEFC Church in Kuala Lumpur. I would like to warmly welcome all of you tonight for our medical talk on aging and care for the elderly by Dr. David Yong, who I will introduce shortly. We hope this is the first of many medical talks that we are planning for the seniors, and it will truly benefit all of you. For the guests in our midst, I'm so glad that you are here to join us tonight. If there are any glitches, please forgive us and bear with us. We are still learning and improving as we do these online webinars or seminars. Well, for tonight, we will be addressing the topic on aging and care for the elderly. As we all grow older, we begin to experience challenges and difficulties we have never encountered before. There are some physical changes that occur in our body, and we face some common physical conditions, such as poor mobility, osteoporosis, dementia, incontinence, and a host of other chronic diseases or disabilities. Few elderly persons escape the accumulation of chronic pathologies as they grow older. Tonight, we are very privileged to have Dr. David Yong here with us to share with his vast experiences on the chronic pathologies affecting the elderly and to provide us with good, caring advice. Dr. David is a consultant in the Division of Community Geriatrics. In his long working experience with the Ministry of Health in Singapore, he pioneered and headed the first community hospital for elderly rehabilitation. Nowadays, he mostly consults in community hospitals and nursing homes, holds teaching appointments, serves as an examiner, and he is still active in quality improvement initiatives in community and long-term care. I'm proud to say that he was my classmate in ACS Tier 1, did his medicine study in NUS, graduating in 1984. He received his training in Singapore, Australia, and USA. So please join me in welcoming Dr. David Yong as I hand the time over to him now. Over to you, Dr. David Yong.
Yeah, thank you very much for this privilege to be able to speak on this topic. So when Jimmy asked me this topic, I guess it's quite hard, you see, and also it's quite lengthy to cover in just 1 hour and leave half an hour for questions and answers. Also, I was thinking about what to talk in this topic because you have aging. So I presume that we also want to know what is the physiological basis for aging and whether we can change the cause of aging so that we don't age, or at least don't age so fast, or at least age well without having to catch all those chronic diseases like Chimoy has mentioned. And then care of the elderly, I was wondering why you want to listen to care of the elderly. So I presume some of us, we are looking after old people like our parents and who may themselves be undergoing some of the problems. So we want to learn. So in other words, as a caregiver, but the other reason could be that all of us are aging. So if you are not submitted to death, then basically you have to age. So because of that, I think these two topics was chosen, but I didn't know that there would be subsequent seminars. So I think I have to talk a bit, I will focus my topic on aging a bit, and then we'll talk about, if got time, 6 principles of care for the elderly. And then I've also prepared 10 common conditions. 2 of them actually absolutely important. And so I'll just begin right away, all right? Okay, so the 3 big issues of the millennium already over, right? 21 years ago, right? When it was the year 2000. Actually, the economy is globalized. So you find that trade is happening at a very fast pace. Can you hear me? Can you hear me?
Yes, Dr. David, you can hear
Can you hear me?
Yes,
All right.
Dr.
Yeah. The second thing is we all information technology, right? So you get social media and you get your handphone with multiple users. But the third, often not so apparent change, and that is affecting all countries in the world, is actually they call it the demographic imperative. Demographic, because it is a change in the social structure, and this has to relate with aging. You see that people are living longer. Imperative means something that you have to face. Okay, you cannot get away from it. So basically, demographic imperative means you cannot get away from this issue of having more older people in your society. All right, so we are going to talk about number 3 today. So many of you do not know this, so I'd like to begin with a little bit of history to say that actually, if you were alive, born, in the 20th century, you would not know that this lady, actually Jean Carmen, is the oldest person. But I want to ask you, who is the oldest person who has ever lived? Anybody? Okay, for interest of time, I'll just answer you. The answer is Methuselah. All right, because Methuselah is 969 years old. Okay, so you say, how do we know Methuselah is the oldest person who ever lived? Because we have to trust the Bible. Do you understand? The Bible, when God says the Bible is true, it is true. So Methuselah is the oldest person. She beats Jean Carmen, but in the 20th century, I think she still holds the record. She still beats the Japanese women. Huh? All right. Okay, so the quest to live long actually has appeared many times. And these 2 time covers show it to you, right? One is how to live to be 100. But we are also very smart. We do not want to just live to be 100. We want to arrive at 100 in good shape, you see. So how to live longer, but also get there well. So these are the 2 topics. We just don't want to live longer and live more our years in sickness on bed. Okay, so this is my most important slide for you to take home. I thought I would say the most important thing right at the very beginning, because I thought on Saturday night, some of you might want to go back and watch TV and then get ready for church tomorrow, and maybe go for supper. So I thought I'll talk about this. So if you learn one thing tonight, that how you can arrive at a good live long by living well, these are the 5 things. Okay, they all begin with W. All right. So the first one is walk. Walk means exercise, and later in my talks you will find that there are 2 types of exercise. The one that all of us know is aerobic. That means we jog or we walk. Aerobic basically makes us breathe in oxygen and then our heart pump faster. This is aerobic. So it exercises our cardiorespiratory system. The other type of exercise that is often missed is actually resistance or strength training, which basically is lifting weights, or in the subsequent topics later on, I will show you what you can do for resistance exercise. But basically, it is moving your muscles against weight, not just exercising your heart. So that's walk. The second important factor for living long is actually weight. Weight has to do with our food. So there are certain foods not to take, to avoid, and there are certain foods that are good. They have shown that in our body, if we were to live long, we would inherit, or rather have more of a certain type of genes. These genes will protect our body, you see, and certain foods will turn on these genes, you see. So it is foods working with our genetic makeup. Of course, genes, we own them because they are passed to us from our parents, you see. Got nobody to blame if you have bad genes, you see. But the point I want to tell you is that weight or food has something to do with living long. And all of us know that, right? The third one is work. Work is not just work as to have employment, but work as to means occupy yourself. Keep your hands busy, keep your brains busy, even after you're retired. That's what we mean by work. Because we are made for an occupation, so to speak, for a purpose. The fourth one actually is less. So 1, 2, 3 is do more. Number 4 is do less. And this one is a real hard one, right? Where we all have worries, but we are not able to get rid totally of worries. But we should try to manage our worries. That means stress. Huh? It has been shown that if you have illnesses, you would be not doing so well in your illness. Let's say you have diabetes or cancer, your prognosis will be worse if you have stress. If you are well, but you worry a lot, then you will become sick. And if you are sick and you have stress, then you may not get better, or you may actually get more problems and so on and so forth. So stress is an important thing for us to manage if you want to live long. Then the last one is wealth. So wealth, people think you must have a lot of money. No, actually in today's society, wealth gives you an independent means so that you can be financially independent, and then you can exert control on the younger generation. Because the moment you release your wealth, actually you lose power. Nobody wants to listen to you. You know what I mean? Your role has taken has fallen behind. So keeping a bit of wealth is enough for yourself is good. Of course, if you make a lot of money and you can give it as a legacy to your next generation, that's good also. But what I meant here was just that enough for you. The other thing about wealth, which I want to highlight to you, is actually friendships, social, all right? Social connectivity. It has been shown, all right? It has been shown that if you have a lot of, not say friends, but social connection, like you're a member of this club, you have these friends to go around with, and then you meet even more new friends and you create new relationships. Interacting with these friends actually has a protective effect on your health, and actually promotes longevity, promotes you to live long and live healthy. People have thought about friends. Why is that so? Number one is probably they help you reduce, number 4, stress, right? Okay. Even though you have burden, but you talk to your friends, your burden becomes less. But the problem is still there, but the burden is less. All of us have experienced that, right? The other thing they have found is that when you have friends, maybe it exerts its protective effect on health, matters. Because in a group of, let's say, 5 women, one of them went for a mammogram, and then they said, did you read in the papers that you should go for screening? Then all the 4 then say they don't know. Then the one will encourage the other 4, and then they will be enlightened, and they will also participate in good health habits or behaviors. So there are many other reasons why having social relationships can benefit us, but these 5 things actually is the basis of self-care for living long and living well. You can put there good sleep, right? But sleep basically works through worry, right? It helps to repair your body systems and also allow you time to rest, to take time off from worry. Okay, so this is the most important slide for all of us who are hoping to grow whole gracefully. And I thought that this would be a simple slide for all of us to remember W, all right? All right. Okay, so we talked a little bit about aging. So nobody knows what aging is. So people put here it's a complex process. It's got a few things. Okay, it starts with number 2 there. There are changes in the body, inside the cells. Inside the cells, because the cells are not so efficient, they don't repair, they don't grow. Okay. And what happens then is that these physiological changes in the cells will produce changes in the body. So then you go to number 3, which is these changes actually make you more susceptible. That means more likely to fall into diseases. So the belief is number 2 at the cellular level, and number 3, which is at the body level where you have diseases. Both of these act together, they gang up, so to speak, and then they make you more likely to fall sick or die. So this is the explanation of what aging is. So it's a very complicated process. All the 3 of them have different mechanisms, but they are also interconnected to one another. But you can see that aging actually is a combination of both genetic and acquired factors. So the gene factors, all right, is usually passed from your parents. Everybody knows this. So if you have two parents who live very long, especially your mother, then the likelihood their likelihood, okay, not 100%. The likelihood is you are to be a survivor, not genetic. The other thing is acquired factors. Acquired factors are those things that after you are born, you live your life, you indulge in your life. So the acquired factors that are not so good will be like your diet, right? Certain high fat diet, high sugar diet, obesity, all right? Say worry, air pollution, an environment that is highly stressful. So, and then you participate in, say, dangerous sports like what are dangerous sports nowadays? Okay. Anyway, you know what I mean by dangerous sport. Okay, say like climbing high mountains and then doing bungee jumping, all that, and then the rope breaks, and then you have only yourself to blame, right? That you have injuries, and as a result of that, you know, you tend to age in a way faster because of the disability that comes with it. All right, so that's the definition of aging. Huh? All right, so we all know this. The world is aging. If this graph applies for Singapore for the last 50 years, it applies for Malaysia, it applies for all the population in the world. If the United Nations was to measure population. So let's look at Singapore and Malaysia. So there you are. The first thing is you see under here, Malaysia, you have about doubling in this number of years, 20 years. In Singapore, it is slightly more than Malaysia. Okay, because we for Singapore, actually having young children is a national in national interest, security reasons. Otherwise, you have all foreigners, so they are always getting people. But anyway, the population aging is going to be increased in older people. And then the other bottom part here is to highlight to you that the life expectancy is actually going up now. Okay, and usually women tend to live longer than men. You see the women here and the men here, women here, men here. Okay, and there are many factors why the two populations have different lifespan, longevity. Okay, so happening all over the world. The main reason is because better education. Okay, so people who are better educated, they know what to eat right, how to live right. They got money. Education brings in money, so they build good houses. They have shelter, protection. They engage in good health habits. So all these contribute towards longevity. These are the main contributors to longevity, not healthcare. Yes, healthcare did contribute, but it's not the major thing, unlike what most people think. And if healthcare was there, it was taking care of infection. That means during that time when the world was experiencing a lot of infectious disease, like right now, COVID-19, which killed a lot of people. So again, healthcare was out there defending the human population from infectious disease, basic things. They're not saving people from stroke, hypertension, heart disease, and these are all diseases as a result of human beings living too long. Then you see diseases like dementia. So the question that we want to ask is, if people are living long, are they spending more of their time in the bed, or are they living their life healthy and happy longer? You see, so that's the question. The answer is they are living long. All right, they're living long. Number two is they are living well, long as well as well. So the world is on track on this question. So when we look at old, not all old are the same. Okay, so basically demographers have classified them into these four classifications that I put, 4 groups: young, old, very old, and special old. Okay, the people above 100 years old, they're special old. And these people, they find very interesting in the studies is that some of them, they have diseases just like each one of us have, normal population, but they seem to survive, or the disease is very mild in them, but they also have diabetes, stroke, but they survive and they can reach 100 years old. Then another group, they don't have all these diseases until they are 99 years old or 90 years old. Then they get diabetes, they get high blood pressure, their stroke is there. See? So these people are called the delayers, the delayed manifestation of disease. And then there's another special group at 100. The genes is so strong, their life habits are so good, they don't have any of those chronic diseases. These are called the escapers. So basically, whichever group we are, the thing is the combination of good genes as well as good habits. Genes we can forget, right? Because we already passed that. So we focus on the habits. Okay. Now, if you look at all these four groups, the fastest growing population is actually the 100 years old. Right? It's actually the 100 years old, not the young old. It's actually the oldest old. Okay. So for governments, they are very worried, you see, because above 85 and above 100 is the fastest growing among the old. We're not talking about babies, middle age, and working population and old age. We're talking about old people. Among old people, the oldest old are growing the fastest. So if you look at the population, then there is worry, because these group of people, you have to think of retirement age. If they retire early, how is the retirement fund going to fund them for the next 30 years or 40 years, right? That's one. Two is healthcare needs will come in the older you are. See, you have a lot of chronic diseases. Chronic diseases don't go away. Later, we'll talk about it if we have time, you see. So basically, this is going to be economic cost to people. But having said that, the thing is that the world has never been in this situation before. The world has experienced pandemic before. Last time, right? They say the Spanish flu and all these things. Now we have COVID. Of course, we were not born at that time, but history books tell us that they have experienced it before. All right, but the thing is about aging population, people living to hundreds of years old as it is now, has never been experienced before in the modern century. So basically, this is an entirely new thing, more new to the world than COVID is for the world. Okay, all right. So this, of course, besides healthcare, also proposes social issues. All right, I always get this wrong. Okay, this slide just very quickly tells you that at all these years, you see, this is a number of people who survive, who live long, and then this is the age of the person. So let's say we take here 50% of the population in the year 1900. In the year 1950, the population is about 55 years old, but 50% of population in the year 80 years later, they will be 80 years old. See, so they are older, 50% of the population. So this graph of survival versus age basically moves to the right, we say, which indicates people are living long. The ideal one we want is actually for the graph to come like that. See, like that, all the way until the time when you die. Then you drop, go straight down, so that the change from 100% to till death, all right, is very small, which is shown here. This is currently our present day morbidity. So let's say you start to have morbidity, means the disease comes. Let's say you see a doctor and then you have high blood pressure or diabetes, you get diagnosed there. And then later mortality, that's the age at which you die there. See, so life extension just means you have have the disease at this particular age, then you just live longer. But the longer length of life translates into the area under the curve worse, you see, more area under the curve. You don't want to have more area under the curve, because more area under the curve are bad years, you see. So you're just living long, but bad, in bed, cannot walk, need people to help you. So it must be quite sad, right? Not only for you, suffering for you, for the family, also the cost of care, you see, right? So the question is that we try to find out whether this is happening, shift to the right, you see. And so there is evidence of shift to the right. In other words, you are getting the disease much later, but the time in which you have expected to live is not that much, you see. So basically, shift to the right is what this is showing right now. You understand the curve? The ideal we want to come to is this thing called compression of mobility, where everything we want to have good years, the illness postpone as long as possible for you to live as long as possible. So I always say, live long, live well. No point live long if you don't live well. So how do we live long and well? The thing is to focus on living well. Nobody can focus on living long, right? We cannot say I want to live how many years, you say, but every day, right? And every week, then every month, then every year, we find that we have lived well, then more years will be added to you. So the two things that determine how long you live, right now I can tell you how long you live, right? Is number one, how old you are now. The older you are, the longer you're going to live longer than the number of years that you have during the birth. So in other words, if you are born the time you have, they say the predictors show that you can live until 68 years old. But now if you are at 65, you can live beyond 68. You see, another 12 more years will be added to you, so you'll be 70 something. So the age at which you are now will predict how long more. That means extra years given to you. The other one is your genes. I told you, right? All right. Okay. I hope that is something useful for you, since we're talking about aging. All right. So just a few slides there. Okay. So now let's talk about the second part, which is about looking after old people who are sick. So when we look at health in general, we can easily classify health. I mean, this is a good classification. How we do it, how we look at people is that first, are they sick or not? Sick means they have illness, they have conditions like diabetes, high cholesterol. That. Number two is, are they disabled or not? Disabled means cannot do certain things by themselves, like walk by themselves, bathe by themselves. They need somebody to look after them, somebody to help them. All right. So this particular classification, class 1 to class 5. Number one, no disease. I think this one is not possible because even babies, of course, you see them, no disease, but when you do investigations, you will find that you will uncover certain things. All right. But there's no need for treatment for that. See, right? So it's hard to say number one, but definitely the baby is able, as she grows up, will be normal human being, so to speak. So number 2, number 3, number 4 is all disease, except for number 5, which is impending death. Right? It doesn't matter. The disease is usually very advanced, and the person's disability is very advanced. The most advanced thing that the most simple thing that you must be able to do is eat yourself. The moment you cannot eat by yourself and somebody has to feed you, that means you are very sick. Unless you have something very recent, like you went to hospital because of an infection, chest infection, and then you were a bit confused and someone has to feed you, that's different. But we're talking about chronic over the last number of years due to dementia. Last time can walk and eat, and now slowly cannot eat. Cannot eat is actually the last thing to go. We call it milestone. Milestones, you know, like you're traveling to the country, you want to arrive at Sitiawan, you look at a milestone, 70 kilometers, 20 kilometers. This one is maybe 10 kilometers before you reach Sitiawan. So something like that. All right. So basically, geriatric medicine, you bring the old person to see the doctor for number 4 and number 5. For number 4 and number 5. Number 1, 2, 3, because people are living long and well, they can still go to the multiple specialists. So if you got heart, you go and see heart. But people who have geriatric problems, all right, are those in number 4. They have the disease, right? They have diabetes, hypertension, stroke, dementia on it, but they cannot look after themselves. That sort of patients you should bring to geriatrics. Okay, so obviously the goals of care are different from each one. Those who are having the disease without any loss of function, you want to control the disease, right? So that they don't. First of all, if you have no disease, you want to find out, is there any risk of you getting the disease? And if there are, then I want to control those risks. So example is obesity. You see, obesity is a risk for many diseases, heart, lung, cancer, arthritis, all that, right? So obesity is not a disease. See? Some people call obesity a disease. But if you find an obese person, then you want to get the person out of obesity. Then you can prevent all the heartaches, which is disease later on. So number one, you want to prevent. Number two, and then if you have number three or number four, you still want to control the disease in all these groups. But number three and number four, you want to spend time on rehabilitating the person. You want to get the person back again with the loss of function. You see, so this classification is useful to help us understand what stage of the disease the person is and how severe is the disease, and also tell us first the severity. It also tells us what type of care is needed for this person. Okay, so this is the first slide to share with you. Okay, so the question is, how come from here these people start with disease, then they end up here, you see? So basically, this slide tries to answer that. First, you have yourself to blame. First of all, age-related changes. This one, everybody, as we grow older, certain things change. For example, you go into a dark room, your eye take longer time to adjust to the light there, right? Some people say cataract is also age-related changes. Other people argue because the difference between age and disease sometimes quite difficult to say which one is disease, which one is due to old age itself. Okay, but anyway, age-related changes. All right. Then behavior is very important. You see, behaviors is our lifestyle behaviors. The hardest thing for doctors when we look after old people or any patient with chronic disease like diabetes, hypertension, heart disease, stroke, and all that, is actually to talk to them. You say yes, agree. Then after that, you go back and see them again. You check the blood, you find that they bluff you, see, because the blood tests show that they didn't follow through their yeah, I see. You see, they cheat on you. So this is human behavior, right? But we don't stop them from coming to see the doctor. Okay, so human behaviors means food you eat, lack of exercise, smoking. These are things which not so good. I won't say they are bad as in moral sense, but basically these are choices. Every human being has a choice. That is very important, right? But the second important thing to remember is every choice has a consequence, you see, right? This is true to spiritual life also, not just healthcare, right? Then we mentioned genetics already, and then of course, in the genetics and health style, you will have certain diseases. So these are the four things that affect the human being. Then the environment is very important. The environment. So where the person lives, whether the patient has a caregiver, if you need help, then the caregiver is very important. If you have a good relationship with a caregiver can look out for you, can be trusted, can be close, provide for you not just social care, but also spiritual, as your friend and all that, like I told you, social connectivity, all right? And then if you are not well, using other facilities like social facilities, okay, like a daycare, all these will help you to improve your health, okay? So basically, under the environment part is this, what I wanted to say. If you are healthy, you don't need to bother too much about the environment. But if you are not healthy, then the environment will help you adapt to that level of health. Say, for example, I give you an example, right? Your knee is painful. You cannot climb stairs, okay? Right? But your bedroom is upstairs. So what are you going to do? Are you going to install a lift? Well, I suppose if you have money, you can do that, or even a stair crawl to put it up. All this can be done, right? But the simple way is actually move the bedroom and sleep downstairs, which all of you know. So this is the importance of, it shows you the importance of the environment, you see, where you don't need to treat the knee pain. It would be good if you can treat the knee pain, but many things in old people, you do not want to treat. The old person may not want to treat, and even treating it may not produce a marked change in the results, you see. Therefore, you must use more conservative measures, right? So wisdom dictates that you must then look at the environment. So the environment assumes greater importance when the person is disabled, just from this slide, okay? Okay, Chui Moi, so far okay enough? Since you are my classmate.
Yes.
Okay, okay. All right, let's carry on. Okay, so you need a list of the elderly, all right? So the elderly is sick. So what do? First, you go and see a doctor, right? So the doctor will say, okay, your mother needs this treatment. So if you look at the needs of the elderly at any point in time, all right, whether he's staying at home or whether he's sick, there are 4 needs, okay? For if they are well, you want to keep them well. You want to keep them healthy. So keep them healthy means get them to walk, get them to do their own things, get them to laugh, get them to enjoy their life, play mahjong, travel, do all those things. Keep alive and keep healthy. All these things are on track, especially if somebody is living to 85, how to teach her. Who am I to teach her what to do, right? But the idea is keep them healthy. So the common things that make them unhappy or sick is usually things like pain, right? 2, worry, right? 3, cataract. 4, sometimes social issues, okay? All right, and then disease will be things like high blood pressure, diabetes. So this may need some control, but you don't have to control too tightly also, depending on the function of the older person, whether he has dementia and all that. So if they are well, want to keep them well, maintaining, that is doing something right. The second thing, if they're sick, then they need to go to the sick bay. So acute hospital for treatment, ICU if necessary, all right? And the doctors there will decide whether you need ICU or not. Then if you have disability, which many of them have, disability is loss of ability to do certain things that you're required to do to remain independent. So I told you, feeding, wear your clothes, combing your hair, brush your teeth, bathing, dressing, all this. And then later on, it will be things like how do you get food? How do you take your own medications? These are all activities of daily living. So if you have disability, especially recent, in the last few weeks, let's say you go to hospital, stay, and then come back, you cannot walk, you become worse off. This is disability. So if you have disability, rehab is needed. Then the last group is actually they are constantly sick. You visit them in nursing homes or in own homes looked after by maids. And so these people basically they are dying. So basically we treat the pain for the doctors, but the spiritual needs also important, the social needs also important, because although they are dying, they are also living, and they are also same for us. Although we are living, we are also dying. Okay. All right. So these are the 4 needs of older people. So the goals of care for them generally are this. Whatever the doctor sees the older person, his main, my duty is to think of ways how to improve the person's function, allow the person to do more. That means last time sleepy, make him more alert. Last time moody, don't want to laugh. Now I tell joke, I want him to laugh. Last time can walk. Now I want him to walk further, walk back faster. Last time he can eat, I want him to eat more. Last time he only lie in bed. Now he can get up in bed, he can walk with a walking frame. See, so all these little things are worth doing if they promote his functional independence. The second one is I look out for dangers that are happening. They are not so good that may cause him to fall down, to decline, we call it. Not really as in having a fall, but to reduce disability. So example is like low vision. Some old people, they have cataract, vision is no good. They don't tell you, but you have to check. So after checking, you have to tell them vision is very important. And the reason vision is very important is now that you have falls, the vision is even more important than before you had a fall. Because before you had a fall, there are other ways to protect you. But now that you have a fall, you have clearly the vision is going to be one of the main things that are going to protect you from further falls. Then lastly, you cannot help or you cannot cure these people. You cannot make them better by rehab and all that. This group of people, then basically we try and improve their quality of life. I told you already, quality of life, physical and spiritual and social needs. Make sure they are well looked after, their concerns, worries. That's where the church can come in, And then the physical needs obviously is usually treatment of symptoms, like they are breathless, they have pain, they can't sleep, they are giddy, things like that. They cannot pass motion and all that. So quality of life here, I think later I just pass the slide to you. The quality of life are all these things. So when we say, oh, my mother's quality of life. So when you say your mother's quality of life, did you mean you look into all this? that your mother is physically comfortable. You try to allow her to do things. She has privacy. She can choose, or you make the choices for her. Dignity. Yeah? When she goes out, is she dressed properly with dignity? Meaningful activity, not just giving her a coloring book to color like a small child, but meaningful activity. Food enjoyment, individuality, relationship, safety, security, spiritual well-being. So basically, these are the few ingredients that make up this quality of life. Okay, so these are the goals of looking after older people. So now we come to the 6 basic rules, then we finish. We will end here. Start at 8, yeah, correct. So 6 basic rules. This one apply to you if you are, say, looking at an older person, or you have an older person living with you. So you want to keep an eye on the person. I think all of you are probably of the young old, right? If you are the old and here, I don't think this will apply to you, but never mind. So the first thing I want to teach you is that when old people are not well, you must take them seriously. Don't blame them because they are 94 years old and say unkind remarks like, what do you expect? You already live nearly 100 years old. Amma, what do you expect? You are tired all the time. No, not like that. They are entitled to being sick. Okay. So basically, this concept is called ageism. I mustn't discriminate against them. Ageism is bad. Basically, if you think that way, basically you have an attitude that is not good. That if you leave it yourself, if you leave it out yourself, it will also do you no good, and you will not be able to live long and well. So attitudes play what our belief systems is. Play a big part, and the belief system obviously is expressed when we deal with somebody else, and then after that subconsciously we incorporate it and we accept this for ourselves. So it's not a good belief to adopt. So ageism is just like discrimination against religion, against gender, against women, right? Okay, against color of skin, and we know this is not right. So same thing. Old people, when they are not well, they are sick. Okay, not because of old age, but because of sickness. Okay, so first thing. The second thing is that, okay, very often when you look at the old person's medical records, you will find they have many conditions. This is not unexpected because every 10 years, let's say they have 2 diagnoses. So if the disease starts at 40 years old, when they live till 90 years old, they will have 50 years they live. So every 10 they have 2, 5 will have 10. Just 10 diagnoses. So basically the diagnosis is not the important. Diagnosis can tell you why she is not able to do certain things, okay, or why she behaves in a certain way. But the fact is, more important is actually what can she still do in terms of her function. Okay, the function is very important. Function is the ability, like I told you, to do those things that you need to do in order to be independent. Okay, so rehabilitation is very important part of care for older people. All right, so I'll just show you a little bit about function. So remember, function is more important. So you look at these 2 pictures. The lady on the left has a stroke. She can't walk. She's sitting on a wheelchair, and the right hand is holding on to the left hand. All right. The person on your bed bound, the other person on the bed, is very common in a nursing home. He's got a feeding tube, and if you go and talk to him, wake him up, he just open eyes. He cannot talk at all. He can't sit by himself. You have to carry him, move him. In fact, every 2 hours they have to turn him. Otherwise, his skin will break down. All right. So if you look at both their medical records, their records will have, let's say, stroke, high blood pressure, diabetes. See, both of them have the same diagnosis, but they are world of a difference, right, in terms of function. So for the lady, basically her function is better than the other person in bed. So in bed, we can say that the person's disease from stroke, hypertension, and diabetes is more severe, and therefore how we want to treat this person. Let's say both have cough and flu, then they found out have COVID, right? So obviously, if you look at the lady and the man you also will know which one, if you have one bed in ICU, which one you would save, right? This is the fact, right? That it's not that you save the person who is more, the lady on the wheelchair because she's younger. No, it's not that. You save her because her function is better. And why do you save her? Because the function is better. Because function, loss of function, the less function you have, the less likely you are, the more likely you are to be frail and more likely to not succeed in the treatment. You understand? So function will predict the outcome of the treatment. So you have two people like this, all right? The one that I send to ICU is more likely to survive if I pick the lady rather than the man. So therefore, if I don't have enough beds, I will have to choose the lady over the man. In fact, even if I have enough beds, I will not choose the man because the ICU will not have very much impact on the person because he is function-wise, he is quite bad off, so to speak. Okay, so this is just to highlight to you that the diagnosis is good to know, but it's not the main determinant. More important is to try and keep the function. I told you also from the goals of treatment, right? You want to promote function, promote function. So so when we assess function, I thought I'd just show this thing which is quite useful, I think. We divide function into three types of function. One is the B, which is basic activities. ADL stands for activities of daily living. These are things that you should be able to do. So basic activities of daily living, bathing, dressing, and so on and so forth. I told you feeding is the last to go. Instrumental is that which you need to do to remain independent, living alone in Sitiawan or in Kuala Lumpur. Living alone, that means you stay alone there, you must be able to do all these things. Okay, so transport, you can't. You can get a Grab, never mind. That's pass. You pass that. Shopping, you cannot do. Okay, you got a neighbor to do it or daughter-in-law, pass. Okay, money you can handle. If you can't handle your electronic money transfer, never mind. You count money still, it's okay. All right, pass. That you must be able to take your own medication, and then you must be able to get food. So 12 o'clock, maybe you take overnight food and you heat it up, pass. You can go downstairs and buy food, pass. Okay, you get your neighbor, pass. You order tingkat, the guy delivers to your house, pass. So you must be able to do this thing. Then you must be able to get laundry and housekeeping. So if you have a private, I mean, you employ somebody to come and do it part-time, also pass. But you must be able to manage that either yourself or control the situation so that you are able to make use of services in order to procure that. Then you must be able to handle the phone. Okay. Then the advanced one is when you have more than 1 and 2, you go on to advanced. So advanced are usually your occupational or leisure pursuits. So leisure pursuits will be travel, game with mahjong, catching up with friends, right? Then occupational pursuits. So what do old people do in occupation? Two of the things will be, one will be caregiving, right? They care for their spouses, they care for one another, husbands or wife, but usually wives for husband. Then many of them are grandparents. So grandparenting is also a role. And many of them could also be volunteers to the same working organization or church organization or any other organization, or participate in religious activities, clubs, and all these things. So this is advanced activities of daily living. So why do I bother telling all this is this? You see that all of us, we have, according to some theories, all of us try to reach to number 3. So the moment you see sickness happens in old people where function decline, function is lost, they will lose by first starting with advanced activities of daily living. In other words, you don't see this guy coming for your activity, for your church meeting, then you must find out why. Of course, he may stay away because he's busy, but the thing is he could also be sick. So the change in function tells you something. So the change in function will move from advanced activities of daily living to here, it will affect here, and then it will affect this portion, self-care. And from self-care, the thing that they have to do is they will give up. They will not be able to do this first. That's why you always end up with a person wearing diapers and then somebody has to bathe him, or he fell in the toilet or not clean, don't want to bathe and all that. Then eventually it will go down here. And when he gets better, he will also recover this way. Go up, and go this way. So when he deteriorates, he will start from here and come down this way. So what I want to tell you from here is that the function loss, any change in function, tells you that the person is sick. And number two is where the function is tells you how severe the chronic diseases that the old person has had before. All right, how advanced it is. So this is about walking. You see, so this one can walk independently, even though she has a frame. This one walk with assistance and a frame. This one can't walk. Right, just to move from chair to bed or chair to stand, she needs two people to help and a frame. So this one we call transfers. Transfers. The most basic thing. If you're caring for older person, the most basic thing, it's not walking. The most basic thing is to do this. Because if you can do this, transfer, stand, and then sit again. Sit, stand, sit. Then you can bring the person to the toilet. You can bathe the person can sit on a wheelchair. He can listen to radio. He can go outside. He can join society. He can go to a restaurant to have a meal. So this is the key function for mobility. We call this transfers. Okay. Yes. 5 more minutes. Okay, different levels of activities. Right. This is most basic. This is telephone. This is the instrument advanced ADLs. Okay. So so the common cause of functional loss, all right, is that there's all these big groups. Yeah. All right. First thing is whenever there's loss of function, we want to find out whether there's a illness going on, what is happening to the body, and is there something going on with the psychological aspect of the brain, like anxiety, depression, dementia. Then we want to look at drugs. Drugs is a very common cause of loss of function. All right. Then the third one is disuse. Disuse means when they come. For example, you get a maid, right? So the maid does everything for the person. So now the maid leaves after a contract or there's an argument. So now you find that the old person, the normal things which the old person should be able to do, like eating, she doesn't even know how to eat, you see, because this is called disuse, you see, because the caregiver or the environment has taken over the role of the person. So this is not something which is good. But this is an example of disuse. Then, of course, frailty creeping up. We have to talk about frailty next time. So this last sentence is important. What I want you to take away with is that when you see somebody losing function, an old person losing function, you must think that the person might be sick. Must think about might be sick. It may be other reasons. Like I told you here, it could be all these other things. It might be sick. And the sickness could be have something to do with the psychological aspect, like anxiety, depression, dementia. It could be the body is sick, like urine infection, a mild stroke, things like that. Okay. All right. So if you lose function, is he sick? The second thing is if you are sick, if the old person is sick, you can definitely find that the person will lose function and you will have to help the older person. A lot of help is needed to bathe him, to feed him, to change him, etc., until the person recovers. So loss of function indicates sickness, and if you are sick, the consequence will manifest as through the loss of function, and the person will require more help with activities of daily living. Okay. Usually, the cause of the loss of function is multiple. In other words, if somebody has like drowsy, or he had a fall, then it could be infection. It could be some medications that is not correct, and then it could be a mild stroke. So the doctors will have a few things to examine, but these are the common things usually. All right, so it's not so easy, but again, it is not too difficult. It is not so easy because there are many culprits, but it is not too difficult because many of the culprits are the same bad guys, so to speak. Okay, so you always call up this guy, and you always find out whether it's a culprit this time around. Okay, so the third thing is when they are sick and they don't tell you they are sick, so you have to look at them. So I told you the simple way is to ask yourself whether there's been a change in function, whether they are more drowsy, the brain or the body. Are they weaker? They don't eat so much. They cannot. This morning had a fall. Cannot walk so fast. Things like that. All right. So functional loss is an indication of sickness. So these functional loss, actually, there's a nice name. They call it giants of geriatrics. So they all begin with I. So basically, they cannot think clearly. See, impairment of mental function, they get confused. They cannot think clearly. They cannot walk. Instability, they cannot balance, so they have falls. All right, they lie there, they walk less, feel tired, exhausted, immobility is called. And then they are incontinence. The moment they are immobility, they will wet themselves. So you put on a diaper for the person. So these kind of presentations and this kind of things that you see in old people, they indicate these are functional loss. All these indicate that the disease is happening in the older person. Okay, or the person don't eat, inability to cope or be their usual self. You must suspect, keep an eye on it. It may progress, may get worse. So basically, this is how they tell you they are sick. So if you want to know whether she's got a heart attack or not, she will not say she's breathless. She will just be very tired and sleepy because her blood pressure is low, right? So there's not enough blood going to the brain, and then her heart has to pump more, and she's tired because of a heart attack. But she won't tell you, I have chest pain or breathlessness. She'll just show up as all this. She can be confused, drowsy. She can fall down and go to hospital, and they do an ECG or check the heart. Hey, she's got a heart attack. Or she just lie quietly there because she's tired. The heart is tired, it just had a heart attack. And because she's lying down there, oh dear, she can't go to the toilet, so she wet herself. So this is how they tell you they are sick. These are called atypical presentations. These 4 of them, all right? Then 4th one, very quickly, is just remember, although we rely on medication, medication may be harmful. The medications may cause all these 4 things which I mentioned. All these 4 things can be due to medications. In fact, 25% of problems in old people are related to medications. Okay, all right. The reason medication is because a lot of old people have many diseases, so they take many medications. Okay, so these medications interact with one another. The other thing is important is that the condition of the old person actually they are not stable. Basically, the kidney. Last time, healthy kidney, we can take a lot of medicine. We can, our liver can take a lot of medicine and can dispose of them. But now, over the years, the kidney is weaker, the liver is weaker, and therefore, if you still take a lot of medicine, the medicine, first of all, will remain in your body for a longer time. It won't be excreted, you see. So the medicine yesterday you gave, last week you gave one, is still in the body, and then today you still give. So of course, you will become more drowsy because it was a sleeping pill, you see, right? So the body has changed. So not just too many medications, but the older person, the body has also changed over the years. So this we call frailty, which is actually another day if it is if I get invited back, Juman. Okay, so there you are. You read this thing. You get it? So the patient go to the doctor and say, I feel a lot better. And usually the doctor will say, yeah, what medicine I gave you? You say, it's not the medicine you gave me. Actually, it's not. It's what you didn't give me. You stopped all my medicine, therefore I became better. So this is true. This is true. Sometimes the problems can be due to all the medication, and you stop the medications, the patient actually do get better. But of course, you have to monitor very closely. So don't do it yourself. Okay, don't do it yourself. Okay, the 5th one is very important, which I already alluded to, right? That if you are sick, you must pay attention to the environment. The environment, there are 2 things in the environment. Number 1 is the physical environment. The second one is the social environment. So the physical environment, look at this. Physical environment are all the non-living things, okay? So they are sick. They cannot walk, right? But they can play mahjong. How do you do that? They not play mahjong. They shoot billiards, okay? So basically they can, instead of bending over, basically they sit on a chair. So they modify the environment for their pleasure. This one is somebody who has eyesight problem, and it's not cataract. The operation won't restore vision, but the person still need to live alone. So what you can do is you can make the fonts bigger, and you can use magnifying glass, and you can write the name of the drug in big prints. This is an example of a woman with arthritis. So she has to go to the corner 7-Eleven shop, right? She wants to go there. She don't want her family to bring her. She wants to be independent. Remember, we said quality of life. One of the issue in quality of life, one of the factors is actually autonomy, the choice. So she wants to be stubborn. She wants to do that. So if you get her a proper modified walking frame. These are actually not a wheelchair, but a walking frame that's modified with wheels and a chair. She can sit down for a while. Then when the pain is better, she can walk again to talk to the shopkeeper in the 7-Eleven. You can also get the 7-Eleven shopkeeper to close the shop and then come over to her nursing home to talk to her, or come to the house, but it will cost the man some business, you see, and she doesn't want that, you see. So basically, when you have disability, remember the environment is very important. This is toilet to make it higher so that people with knee problems can sit and then stand much easier. This one is a wheelchair, but if you have a motorized wheelchair, even though he doesn't have legs, he can move around. This one I told you just now, that example, right? If you can't walk upstairs, you can install a stair crawl. This is called a stair crawl. You can, for much cheaper than this, get the bedroom moved down here. But then again, this person who wants to use the stair crawl may want to enjoy the bedroom up there with the view. So if she's got money to spend, why not to do that? Okay. So this is the social environment. The social environment is the caregiver, very important. Must look after the caregiver. The caregiver faces a lot of stress. If you look after the caregiver well, this is called the care recipient. Care recipient is called caregiver. So if you look after the caregiver well, the caregiver will look after the care recipient well. See, the two of them is a unit. Okay, we can talk about this another time. Okay, last one, I think. So before you go away thinking that it is too late, no, not true. Even in old age, there are certain things that are still good for prevention. So I just wrote down here, falls and injury. Next time we can talk about this. We can actually tell you who were likely to fall. And because if we know who is likely to fall, then we can change the cause or nature and don't allow you to fall. So we can do that and prevent you from getting an injury. Secondly, aspirin is good. Maybe for the heart, most people have heart, or they have dementia, they've got stroke problems. Okay, so an aspirin is, or other drugs, anticoagulation, heart medication is still good for prevention of stroke and things like that. Blood pressure and diabetes control is still good for prevention. Flu vaccination, and now they say COVID, okay, but there's some disagreement, but never mind. The principle is vaccination against the usual one before COVID come out is flu, then pneumococcal every 5 years, flu every year, right? Screening for vision, hearing, these are problems that are very common in old people. And then when they are present, they do a lot of damage. They do a lot of damage for old people. And then screening for polypharmacy, too much medication. Then screening for sarcopenia and frailty, which is too big a topic. We'll talk about it another time. Okay, so I think with that, I will pass the session over to Chumoy. This one we're not going to do. All right, so I'll just take questions from here.
Okay. Thank you so much, Dr. David, for taking us through aging and caring for the elderly, right? And pointing out all the very important basic rules for healthy living, and of course, finally, is really to live well and to age gracefully, right? So now there are some questions that some of you have posted in. If any of you have any question that you would like to ask Dr. David, so you can actually go to the chat there. There's a link for you. You can click the link, and then you can type your question into the Mentimeter. All right. So, Dr. David, I just want to ask here that two questions. One is, I think this is for the young old. What is an ideal retirement age?
Okay, so the history of retirement age goes back to after the First World War, or before the First World War, actually, more this Bismarck from Germany, right? So he realized that you got to retire people so that the younger generation will have work during that time. There's no proper problem with low fertility, right? So you got to retire old people to give way to the new. So the question is, if you give them an age too early, then the state, that means the country, the government is going to suffer, because you have to sponsor the pension. In those days, it was pension for old people for a longer time, right? For example, if you give them 40 and they live till 70, then 30 years, money gone, right? You see? So where do you put that age? So from that time, they put it about close to 50. But then as the population age, they found that, hey, this is no way, you cannot do it like that because the population is now living longer, you see. So basically, they have pushed the retirement age or the definition of elderly at 60, 55, 60, 62, some countries 65, 67. Some of them, they remove retirement age. And as long as you're fit, can do the job and you want to, you have ability, and the company finds that you are needed, then you will continue to work. Of course, in countries like Singapore, where the fertility rate is low, then basically the working population is also reduced. So you tend to take in more foreigners, but taking foreigners is also not a solution because there are also other national interests which are involved. One of them is social, right? You have social diversity, people working locally, not happy, they say they're stealing our job and all that. So basically, in Singapore right now, I can tell you that it's 62 going on to 65. Okay, so back to the answer to the question is actually, I don't think there's a good retirement age because people are living long. Like I show you from the compression of morbidity, as long as the person is able to, subject to a screening by the employer, prospective employer, then they should be able to do it. But wanting to may not be possible in some societies, and in others, the workplace may also display discrimination practices towards the older person and make them not feel welcome, instead make them feel guilty. So I think I don't have the answer to that.
All right. I think there are so many other factors involved in the retirement age. So there's really no ideal retirement age. All right. So I think basically, as long as you can work and your function is still very good, I would encourage the person to continue working. And that will really also help in living well and living long also, right?
Yes, correct. You're right.
Okay. Yeah. Okay. Another question regarding some elderly who are very sleepy. Is it common that the elderly sleeps more most of the time, regardless of day or night, or at times sleep a lot during daytime and unable to sleep in the night? What do you think?
Okay, first of all, I'll just say two things. First of all, as we age, the amount of sleep remains the same. But the thing is that, so the quantity of sleep remains the same, but the quality of sleep change. The sleep architecture, they call it, is altered. So very often we wake up feeling unsatisfied or feeling like you haven't really slept. That is because in sleep, there are different cycles. So in order for our body to totally relax, we have to go into a very deep sleep a few times, come up, come down and all that. So older people at night when they sleep, they are easily awakened by small things. Some of these symptoms, it's like going to the toilet, pass urine, then you can't sleep. Some people, they wake up, they can't sleep, therefore they go to the pass urine, the other way around. Then you have itch, then you have pain, then you have breathing problems when you lie down, right? So the sleep is interrupted. The second thing I want to tell you is when they are sleepy, there are at least a few reasons. The first one, you have to make sure that if they have been always sleepy, then it's not likely to be something serious. What could happen is that they are sleepy because they are at night, they are awake, and therefore daytime they sleep. So this is called sleep-wake cycle, sleep-wake cycle reversal. All right, and this is found in brain diseases like dementia. Okay, hard to treat. Some people say in the daytime you have to bring them to the sun, keep them occupied, don't let them sleep. Then at night, give them some sleeping medication, but then they will feel tired to sleep. It has been tried, so you can try that. All right. So first is sleep-wake cycle reversal. The second one is actually quite common, boredom. BOREDOM. Because a lot of times old people, right? We don't engage with them. And when you think about it, after you bathe, you give them food, medicine, all that. What is that you want to do? You as the caregiver, you got to prepare for lunch, isn't it, right? Think about something else to do at home, right? And so the older person is left then neglected. So that's why I say in the environment for helping older people, a program, a day program where they go there a few hours is also good for mental stimulation. Also provide respite for the caregiver so that the caregiver can have some hours, if not half a day off, whether for own thing or to do some other thing, just physical and if possible mental rest. So boredom, all right? Then the third one is of course something more serious. So the two common serious, the serious thing means the patient is sick, but the sickness may not be the type which is very dramatic, like he collapsed and all that. It may be slowly appearing. So if it is new, you must think of sickness. And this sickness, there are two of them, two common ones. Okay, the first one is an infection. All right, usually a urine infection. The second one I've mentioned already, medication. So when you give medications to older people, you must also realize that the medication can also do harm. In fact, 25% of complaints in older people as they sit there to see the doctor, this 25% of the complaints are related to medication. Okay, so one, reversal of sleep-wake cycle. Two, boredom. Three, they have what is called delirium. All right, so the key thing is it, have you noted it long time or there's a recent change? Recent change, then number three, something more sinister is happening. Okay, yeah.
Okay, all right. Wow, there is a lot of sleep work to do.
Yeah, that's right.
All right.
Yeah.
So we have to work hard to sleep well also,
No, yeah.
Okay. Yeah. Okay, the next question. What help or exercise can we have for bedridden elderly folks?
Bedridden can prevent.
What kind of exercise would be helpful for bedridden elderly folks?
Okay, so usually, okay, so in terms of function of the patient, where we refer them for recovery to the therapist, we call it, right? So there is physiotherapist, there's occupational therapist, and then there's speech therapist. So the simple way to remember is occupational therapy is for your legs. The legs is to walk. The legs is only to walk, to stand, to squat, and all that. Okay, to walk, to crawl also. The second one is your hands. The hands is occupational therapy. Okay, so if you think about it, all your activities of daily living under instrumental, handle phone, go buy food, cook food, all these things, use your hands, have to use your hands, you see, right? Yeah. Then the legs and the hands work together in certain situations, like you have to bend down, climb up, all right? You go to the toilet, you have to sit, turn around. So the legs working with the hands will do the thing. So hands and legs. Then the third therapy is the mouth. See, the mouth has two things you do in therapy. The first one is swallow and eat. That's very important. The second one is to communicate, to talk. Okay, so this is therapy. So in bed, first of all, I have to find out why person is in bed. But let's say chronic, usually things like dementia, Parkinson's, stroke, old hip fractures, things like that. Okay, or bad arthritis or amputation, whatever. All right, they lose the power and the leg. They're in bed. So what will happen usually is that due to lack of positioning, the legs, the knees will bend. They will bend. This we call it contracture. If you have stroke, your upper limbs, your elbow will also bend. Your fingers will also all bend. This is due to the brain change as a result of stroke. Okay, these are all very common. So a person who is in bed for a long time will always curl up like a baby. All right. So the problem with baby at the time is no more trying. The problem with the old person at this stage, which is late, is no more trying to get the person out of bed. Okay? Because with the bend knee, it's very hard depending on how badly bent it is, it's very hard to get the person to sit on a wheelchair. So even if you can carry the wheelchair is not made for the person to sit because he cannot balance. His knees are all pointing up there. So what is then done for these people is what we call, the only exercise is actually, we call it passive range of movement exercise, PROM. So PROM is the therapist or a therapy aid, or if you have learned it from the therapist, you can do this safely and competently. You have to slowly straighten the knee and slowly pull the hands apart, the fingers and all things. Sometimes roll out a towel or get a thick pipe or something, a short thick rubber pipe for the hands so that they don't scroll up. Okay, why do they still do this even though the person cannot walk or sit anymore? The reason they do this is because when they bend too much, all those surfaces that are bent are closed in. So when they get skin infection, there is a problem. You can't clean it. You see? Do you understand? You can't clean it. So you have to try and protect the joints. That's what I'm trying to say. But before you go stretching it, you have to realize that to stretch and all this, watch out for the face and the groaning and all that. There may be pain. And so don't just go and do it enthusiastically because of pain. Secondly, is usually these joints, they are contracted, we call it, the muscles are shortened. So if you just pull, the muscle will break, and the whole joint can be very bad bleeding inside it. Okay, so unfortunately, these things should have been prevented. Okay, but now let's come to the let's say you can afford every doctor and you think your mother ever told you that if I was to suffer, please remove my suffering. Then you were wondering, what does she mean? Does she mean she wants you to put her under hospice for palliative care? And you figure that no, she wants you to relieve that suffering. Then what you can do is you can go to an orthopedic surgeon or show the pictures to the orthopedic surgeon. Don't bring your mother there. Just discuss with him that for this level of joint contracture, whether he would consider an injection, Botox, we call it, which can go into the muscle and cause the muscle to relax. And then you can straighten it and then put a splint. A splint is like a plaster of Paris over that area so that it doesn't go back again. Or sometimes more drastically, if they cut the muscle, which is usually not done. Okay, so if you really want to do it, you can ask the orthopedic surgeon, and again, it's better if you ask somebody who has experience in this, because the usual orthopedic surgeons, they do many things, just a knee, just hip fractures and all that, so it's good. You can also ask the physiotherapist first before you spend good money on the orthopedic surgeon. The physiotherapist is very well trained and she can tell you what to expect before you make investments. Yeah.
So I think the best first stop will be the physiotherapist to help out on the exercise part. And then if need further diagnosis, that is where the orthopedics can
come in. Yeah.
Okay. All right. Thank you. Okay. The next question. This is regarding dementia. In your opinion, when does dementia normally set in for the elderly?
Okay, actually, for the elderly, okay, that's a trick question, I suppose. There are dementia which runs in family, so you can get very early, okay, 20s, 30 years old, okay. Then there's dementia that is associated with certain conditions, in genetic conditions. So this genetic condition, one is that, it's called progeria. You can go back and look up pro means opposite of anti, anti against, pro means for, geria, G-E-R-I-A, geriatrics, old. Pro means faster aging. There's a gene defect. These people actually at 20 years old, teenagers, they look like old people, white hair, bones crooked, they have stroke, heart attacks, and all that. They die at that time. Progeria, gene condition. Okay, then there is this more common one, they make Down syndrome. So Down syndrome, they have mental impairment, but actually in their brain, they are wired for dementia. So all this can happen before elderly. Before elderly. So just elderly alone is not a good cutoff age. In other words, the dementia can happen at 40, 50, 60 years old, even before you reach the elderly. Okay, so the two common cause of dementia is Alzheimer's and the stroke related, or what we call vascular or multiple strokes. Okay, so Alzheimer's is by far the most common in the world, in Malaysia as well as in Singapore. But the one due to strokes, okay, is second most common. But in this part of the world, Asian countries, because we have more diabetes, hypertension, the proportion of stroke actually increased. But the most common is still Alzheimer's. Okay, so if you have a younger person, you have strokes, diabetes, you didn't take care, you got heart attacks, you go for bypass at 40, then maybe at 50 or even 60 years old, your dementia would have come before you even become elderly. And that can happen because strokes damage your brain, you see. You know what I mean? So the question is not what's the age to get dementia. So that's wrong, not so good. I won't say wrong, so I don't antagonize the questioner. Okay, so I just say a bit more. Now the interest is not so much dementia or no dementia. Actually, I have a nice slides. I prepared 10 common conditions. We can do it next time. Okay, and we'll talk about osteoporosis and dementia because these are two main things.
Right.
Okay, so anyway, now the interest is in actually what we call pre-dementia. That means I test your mind and I find that you, according to some tools that we use, basically you didn't pass, but then you didn't fail too bad also. So you are somewhere in the middle gray zone. So what to do? We just wait until 6 months, 1 year later. So they have shown that this group of people, about 10 to 20% of them actually progress to dementia. But this is also the time where if you go for this screening, they recommend at 65. So now you got what age you go screen health disease. So okay, retirement age you go for health, total health screening. But what time do you go? I mean, when do you go for screening of diabetes and high blood pressure? Depends. If diabetes and high blood pressure is very common, like in Singapore, then they recommend at 40 years old, 40, the GP should start screening for diabetes, hypertension, and cholesterol. So same thing for cognitive impairment, for cognitive problem, memory problem, they recommend 65. This is not international yet, but I just tell you. So the idea is that you can find something abnormal, that your memory is not so good, but not dementia. Don't worry, not dementia. Anyway, only 10 to 20% progress to dementia. You may be the 80% who escape. Most of them actually is not dementia. All right. There are other things like depression on that, but they find that your lifestyle is no good and is causing your brain to be stressed. You see, for example, you have too much stress, you take too much high cholesterol food, your blood pressure is not controlled, and then you're not taking aspirin, diabetes not too good, right? And your food substance, you could do better eating Mediterranean diet or that. So the thing about this group is that you can screen them, find out what is that their brain is not so good, the memory, and then do something about it. Do something about it. You do something about it not because you are afraid of dementia, which you probably won't get, but you do something about it because it's abnormal. It's just like you found out that your heart is not so good, you do something about it. Not because you want to go for bypass and all that. You found that, oh, your cholesterol is, your ECG is not so normal. So maybe you should be more careful with what you eat and things like that. Yeah, we'll deal with this next time when we do dementia, how you tell dementia from normal aging, all right?
Yes. I think we will have another session to talk in more detail about this some of these specific illnesses that the elderly are more common to encounter with. Yeah. So okay, it's already 9:30. So let me ask you one last question.
Okay. You are. You ask me. Yeah.
Yeah, okay. I will ask you. This is the last question. I think sometimes the patient, the elderly patient, they lose their motivation to live. How do we help this the case like this, and what can we do for them?
Okay, that's good. All right. So we see this group of people, motivation to live. So when they lose the motivation to live, some of them in the hospital, like rehab hospital, we find that they don't want to eat. Then they don't participate in care. We ask them to bathe, they don't want, they refuse, they stay in bed. We ask them to come out, do exercise, they don't want. Okay, all these things. So we asked them in the past, do you have any problems? No, my grandfather is not like that before. Suddenly after he's sick, he becomes like that. So our first diagnosis is first, make sure he is not sick. That means he doesn't have infection, he's not under the influence of medication and all that. This we call delirium, which I will cover another time. He's not acutely sick. His thyroid is okay, his calcium is okay, because there are certain things happening in the body where he is sick, which he can have low motivation. Okay. Then the second one is, of course, we diagnose dementia. Okay, they are not dementia, sorry. We diagnose depression. Okay, and then we start him on antidepressants. And while we are starting on that, basically in the hospital, we try to keep him alive. We have to talk to the family and sometimes have to tube feed him. And sometimes if he resists, he fights, we have to get the psychiatrist in. And sometimes if he is really bad, we may have to give him brain shocks. Okay, although he has never become so bad, unless he's violent and aggressive and try to kill himself, suicidal. Okay, so low motivation to treat, actually the diagnosis you should think of is actually depression. Okay, so now let me talk to you about depression. So when we think of depression, you think, okay, take pills. This is not true, right? Depression, there are 3 or 4 things related to the mood. Depression is a sickness, just like you got diabetes, you got stroke, you got high blood pressure, right? So there's nothing unusual about it and nothing to be shy of. Okay, it can just come off like that. Sometimes people ask, oh, your children are grown up, you're so successful, why you get depression? Not why, is you don't know why. So the first thing is that there's some chemicals in the brain that's gone a bit haywire. These are neurotransmitters in the brain, usually serotonin and noradrenaline. So basically the treatment is drugs for this. Okay, then the second one is we must look at the whole person, right? The second thing, whole person. So psychotherapy helps. Psychotherapy, you can say tender loving care, a pat on the back, pep talk, pray together, bring him out, show care, love, concern, all these things. Okay, that helps. Okay, these are all under psychotherapy. Psycho, the brain. You're not using medication. You're just talking to the person. So friendships and all this. Okay. Then the third one is try to improve the social situation. Sometimes the lack of motivation is due to a social situation. This is hard to address because who can go into a family and after 50 years of animosity or bad links, how can you change this, right? But you try nevertheless if you can. Social. Then the last one is at the same time try to improve his function through exercise, trying to encourage him small things like just instead of lying down in bed, just help me to sit him out. Then if you sit out, then I can bring you down to the coffee shop downstairs to smell the coffee, things like that, you see. So these 4 things: medicine, psychotherapy, try to attend or change the social situation or make it right. Then the last one is improve the function through therapy, physio, occupational therapy. These are the 4 things we do. So if you do have a patient like that, you should refer that patient for motivation. This is one of those things to the geriatric doctor. He'll be very interested in that. Yeah. So wait, haven't finished. I know, got to let you off. Okay, got to let you off. Okay, so if you ask the doctor will have to give a diagnosis. This diagnosis, in order to get money, it has to come from a book which the United Nations or the International Code for Diseases have published. So they inside there coded, like you have a fall fracture, this is the ICD code, we call it. It has a number on it, okay? Number on it. Then when you write it inside our case notes, the ministry will pay for this code. So when you ask for this kind of condition, they will quote depression or depressive illness and other things. But I have also met many people who actually have no will, W-I-L. In other words, they have an existential crisis, you see. And this one goes beyond our medical diagnosis of depression. If you ask this patient, you are assuming that this person has a medical reason behind it, and that is correct. You should use the medical model to see whether there is something medical, like his hormones or not. getting well, or he has a tumor and all that, he should do that. But I will tell you this also, that it goes, the no motivation to live goes beyond the diagnosis, the medical diagnosis of depression. In other words, making a diagnosis of depression and treating the depression as according to what I've just said may not be the answer to everything. After the patient goes home, he may still suicide, because the motivation to live is more than depression. That's what I also just want to end up saying. Yeah, there may be spiritual things to it. Yeah.
All right.
Yeah.
Okay. Well, one more thing is, I think some of the participants would like to request for the slide that you did during the talk. Would that be able to be made available to them?
Yeah. So because the slides cover the other topics which I haven't talked yet, I will just slice up those ones that I have spoken to. And then if there are pictures, I will remove them. The pictures is because they are patients. So this is for patient confidentiality. Otherwise, I'll be very, very happy, because the whole idea is to change our mind, and then we can be agents of others to change others too. Thank you very much once again for your spending time listening to me on a Saturday night. I'm sure you have a lot of better things to do.
Actually, we should be the one thanking you, Dr. David, for your enlightening and helpful talk on how we can cope with aging. And we didn't know aging is such a complex matter. And today I learned a new word, ageism. Wow, this is something
ageism.
that I would,
So
I would tell my children, don't be racist, don't be ageism. And also provide care for the elderly in our homes. So to all the participants tonight, as Dr. Day had advised us right at the start, to do more walking, do more weight resistance, do more work to occupy ourselves. All this will be really helpful. Do less worrying, right? Because you can't change anything with your worrying. And of course, just have enough wealth to keep yourself well, to be able to take care of yourself. So we hope this talk has helped you to understand the process of aging better, and how to take good care of yourself or your elderly ones at home, so that they can have a full life for as long as possible, to live well, to live long. All right?
Can I just
yes.
Yeah, just interrupt. No, the walk is number one. Weight is our diet. Weight is our diet. The W is actually your diet. Good food to take. Good food to take, like olive oil, antioxidants, things like that. You know, the red wine, all that. Then bad foods to avoid. All right. Then wealth, very important. One is the physical, the wealth, assets and money. But the other wealth is people, relationships, your friends, people. That's what I mean. And actually, having relationships is correlated with living long and well. Yeah.
Okay.
Thank you for the time. Thank you. Yeah.
All right. So to all of you, if you have any interesting topics that you would like us to organize, do let us know through the email, so that we can look into planning for it. So let me end tonight's talk by wishing you good health, and may you still bear fruit in old age. May you stay fresh and green. Thank you all for joining. God bless and good night.
Thank you.
Thank you so much.
Okay, I'll leave. Thank you, Chumui. Thank you to all your team. All right, yeah. Just write to me. Write to me and see how we do it.
Yeah, bye-bye.
Right? Yeah, bye-bye. Good night.
Okay. Thank you, Dr. David.
Bye-bye. Yeah, bye-bye.
Thank you, doctor.
Thank you.
Thank you,
for all
doctor.
your,
Thank you. Bye-bye.
Thank you.
Thank you. Thank you, doctor.